So our next session will be a panel discussion. The session will explore how innovative technologies can be successfully adapted and scaled to address critical development challenges in healthcare. The panel will be sharing real-world stories and practical solutions from the training of local teams and handling patients to finding ways to make these projects lasting, impactful, and very tailored to the LMIC, lower middle income countries. So among our panelists will be our recent speaker, Mr. Joshua Ametepe. We'll have Mr. Cowles Chilongulo, Mr. Tom Esweu, and I think Ms. Jacqueline Thairu will also be joining us. So I'll welcome Mr. Cowles for a brief introduction. Mr. Chilongulo, are you there?
Yes, I'm here. Can you hear me?
Yes, we can. Welcome to our panel.
Thank you.
You can briefly introduce yourself.
Okay. My name is Cowles Chilongulo. I'm from Blantyre, Malawi. Precisely, I'm an MRI radiographer. I've been working for the Blantyre Malaria Project, in which we have been doing MRI studies, mostly focusing on cerebral malaria. And one of the studies that we did was the one mentioned by Mr. Joshua, brain imaging in normal kids, which we did in 2012 and 2013. But other than that, we have also been doing several studies, which I will elaborate, I think, sometime later. So we started with an MRI in 2008, which was 0.35 Tesla. And then it broke down in 2019. And then we started using the low field hyperfine 64 mil Tesla, which we are using up to now. But recently we have acquired three 1.5 Tesla scanners, which have been installed in the three major hospitals in the country. And so briefly, I have been doing this, I think, for the past 16 or 17 years. And most of the works that I've been doing are a mix of research and also clinical work. So my interest, mostly because of the nature of the studies that we've been doing, was mostly brain studies. So I'm mostly conversant with brain MRIs. Yeah. So I am one of the members of the ISMRT or ISMRM as alluded earlier. We have the African chapter, and Jackie and I, we serve as members of that team. Through that team, we have been sharing a lot of information, a lot of teachings, and as the previous speaker has said, there's been a lot of collaborative efforts to share knowledge in terms of MRI issues. And so this has really helped most of us, especially in Malawi, as a low income country with very few MRIs. As I'm saying, we only have acquired these three 1.5 Tesla machines this year. Previously, we only had one MRI in the whole country. You can imagine how that has
We've lost you, Mr. Chilongulo. You are on mute.
got mute. Sorry. Yeah, so briefly, that's me. And I just prepared some presentation, but I think this will be shared as the discussion is going on.
Thank you so much, Mr. Cowles, and thank you for the highlights of Malawi. We'll definitely be engaging more on that to understand more on Malawi.
Yes.
I'll welcome. Yes, thank you. Mr. Tom, welcome. You can introduce yourself.
Thank you, Cliff. Good evening, colleagues, dear friends, and good to meet you. It's been long since we had sessions together. My name is Esweu Tom. I'm an imaging technologist. I worked in South Sudan, where I was privileged to serve in only one MRI machine, a low field, 0.5 Tesla, the whole country. That is how the situation is in South Sudan, a landmass of close to 12.9 million citizens. So we only have one MRI in South Sudan, located in a city called Juba. And like we see these discussions, we may take them lightly, but the truth is in low and middle income countries, we are facing challenges accessing this imaging service, that is MRI. Though we have X-rays, we have ultrasounds, we have CT scans in place, MRI is still scarce. And like my friend shared before, Joshua, I was just so amazed how he's talking about how he's working on improving on signal to noise, removing noise from the images. I think that's the biggest challenge we have, especially when we're trying to do diffusion, weighted images for brain imaging. We get a lot of noise and the images are really terrible. So I hope your research and invention will save the colleagues who are working with low field MRIs. So, but at the moment, I'm in Uganda working with Avison International Center, and probably no MRI at the moment, but we look forward to advocating for these services in our country. Both Uganda and South Sudan, they have the same challenge. In Uganda, we have only about 14 MRIs, most of them in urban settings, and about 4 are low field. Actually, when we put the real definition, about 10 are low field, only 3 or 2 are high field in the system. So that is who I am, basically. I have benefited from ISMRT, which I joined last year. I've also benefited from cameras, and I always keep following the trainings that are on. I benefited from swim program, training program, and completed. I'm really, really so amazed and so happy with how the partners are coming up to empower the low income and middle income countries with knowledge. Thank you so much.
Thank you, Tom, for that introduction and painting the picture in South Sudan and as it is in many African countries. We'll also get to discuss that in detail. Jacqueline Thairo, are you there to also make an introduction?
Hello, everyone. I might not be able to have my video on, but my name is Jacqueline Thairo. I'm an MRI radiographer from Nairobi, Kenya, but I'm currently doing the ISMRM Gates Knowledge Exchange Program at Cardiff University. And I'm happy to be here. I'm happy and excited for this panel discussion. So please take it away.
Thank you so much. We heard from Joshua, so we must keep this introduction part for now. So today's panel, as we've highlighted before, we're just trying to emphasize the challenges and some innovations that will be relevant to Africa. So the one thing we've talked about from our panelists have engaged more on is the accessibility challenges and the infrastructure. So LMIC faces significant barriers, like the low number of MRIs and unreliable power, which is evident in many African countries, coupled with maintenance and downtime of equipment, as Cowles has mentioned. So we just want to have a brief discussion on how have you experienced these infrastructure gaps? Yes, you have, and how how are you trying to manage it, or how is it being managed in your respective countries? And probably add on what low-cost adaptations that you think can bridge the gap and help access MRI in your countries. And so we'll go with Cowles.
Thank you very much. As I mentioned earlier, so we had a 0.35 Tesla, which was a GE machine. We had it for 11 years, and one of the problems that we encountered was the unreliable power supply. And I think during one of such incidents, so many things blew up in the control room. And when the engineers tried to come and do the repairs, they could not manage to resuscitate the machine. So we had to stop using it. And so from there, because we had a research study that was ongoing, it was decided that we get the hyperfine 64 mil Tesla machine, which we acquired from Hyperfine, and we were one of the earliest countries to acquire that machine, which was in 2021. And when we got it, we started using it to do the scans, and we continued with the research study that we were doing until we got to the end of it. And so despite having that experience, we discovered that one of the problems that we have in the country is the fact that we don't have a medical physicist at the hospital. Just to mention to you that we only have 2 medical physicists in the whole country, and these people are stationed at the 2 cancer centers. They are not working in the hospitals where they could offer some of the their expertise in terms of equipment sustainability. So apart from the issue of power supplies and the like, I think the fact that we do not have the medical physicists was that it sort of gave us a handicap in which we could not sustain our magnet for a long time. So when as I said earlier, that we have just acquired the 3 1.5 Tesla scanners, which are just about 6 months old. And since they are relatively new, we haven't had any issues yet. But from my experience, I have instructed the authorities that one of the biggest problems in sustaining these machines is the issue of maintenance. And so without the preventive maintenance services, usually we see these problems surfacing every time. I was very interested to hear to the first speaker and also what Joshua said about the issue of making these things available within the countries, having these engineers. We can make our own coils, we can do some of these things on our own. And one of the things that I think this program should focus on is how to make sure that these MRI machines are sustainable in low income countries, because as you are aware, uh, because they are very expensive to have the service contracts, which was one of our biggest problems. Also, we had a big problem. The service contract with GE, the manufacturer, was very expensive, and for part of the remaining years that we used it, it was not very easy to have it with the company, and therefore, when that happens, then you continue to have problems because you don't have service engineers from the manufacturer. As you are aware that these manufacturing companies, they want you to have service from their own engineers, and that becomes a very big problem if you don't have a service contract. Let me stop there for the moment.
Thank you. So those are the challenges that I think most of us can relate about, especially with the electricity and the service contract, which is very expensive. Are there any options you are exploring to mitigate these goals?
At the moment, the only thing that we have, because the only thing that we have tried to advise our authorities is to make sure that we must, because as you know, these machines, they come mostly as donations. So when they are donating this equipment, what happens is that it's only the bosses who sit at the table accepting the donations. They leave out sometimes most of the technical people who can argue to say that when you are donating a machine, for example, the buying is not all that is a problem, but sustaining the machine. And therefore, if they are donating the machine, they should put in some factor regarding maintenance and service contracts. And so far, what the authorities have done is they have listened to that argument. We only hope that they are going to implement it in practice, because they have just accepted and accepted this in words only, not in action. So as I advise them that when the new machines start giving us problems, we should have the service contracts ready. The other thing that we tried to do was to work with the service engineers online, so that every time you have an issue which you have seen on your images, you get in touch with them as soon as possible. And we discovered that one of the challenges that we were facing was easily sorted out, even without the need to have an engineer to come down to Malawi for the repair. And on top of that, I think the fact that when they are bringing the machine, there are three things that are very, very crucial, which from our experience, we discovered that every time we have a problem, it was maybe one of these things. And this was just that the electricity supply, you need to have a strong UPS, which of course is supplied, but then you also have a ready genset, a generator, which when there is a power outage, there should be an automatic connection from the lost power to the generator, so that you have continuous power supply. But also apart from that, we used to have problems with cooling and the issue of air conditioners. And so we also solved that by having contractors who were supplying us, maintaining and providing air conditioning and cooling in the scanner, as well as in the control room. With them, so that every time we have an issue, we just call them, they rush, get the problem sorted out, and then we are good to go. So just like with the other things as well, we also had the contract with the people who supplied us with the generator, and every time there was an issue, we would have that. So we discovered that this helped us quite a lot. And these are locally sourced services that help to power up our MRI without having any problems.
Great mitigation points there. So portable ultra low field are emerging as game changers, and I want Joshua to comment on it alongside if infrastructure and accessibility challenges are also something common in Ghana. Do you feel portable ultra low field is a sustainable model to replace these challenges? You are on mute, Joshua.
Yeah, apologies. Thank you very much once again. So I guess I should start by trying to address what I can regarding the accessibility challenges. I may not have much knowledge, but like I said, I worked with a company that supplied these equipment to different places across the country. And the money was naturally not just the only issue, as Mr. Cowles mentioned. Uh, Sustaining the equipment were always a problem. So with where I worked, for example, a lot of times the manufacturers, if they want to, would give training to the engineers in the distribution company so that the engineers can also go and work on the equipment if the equipment have a problem. Sometimes the manufacturers can just decide not to do that. In certain instances, when some equipment are supplied, I remember there was an issue with an X-ray scanner that I went to work with. The manufacturers provided one version of their manuals, and the other version of the manual they kept to themselves, and that contained a lot of detailed information that you could use to actually solve some of the problems, including how to calibrate the scanner, which wasn't really difficult. It just involved putting a phantom with the scanner and pushing certain buttons on the software, and the scanner calibrates itself. But that information was missing from the manual that we were given, even though it was a service manual, which shows a bit of problem. So when issues come like that, you need to find ways of contacting the manufacturers and then speaking to their engineers, who would probably be awake at different times of the day because of changes, or they fly from their country to come to the hospital to work on problems, which I understand some of the problems are very specific and they don't want anybody messing with it. But some of the problems are not. And some of them just involve them taking over their computer using Teams viewer, clicking on a few things, and the problem is solved. Which, yeah. And a lot of it also involves signing service contracts annually, which if the hospitals do not pay and those monies are very expensive, it becomes a massive challenge. And those are some of the ones that I have seen. And there have been cases where a lot of the equipment have been abandoned. They go bad, and some of the problems are solvable if you learn more about it, if the information is given. But because the information isn't given, the equipment is just abandoned, never to be used. And it's not just that the equipment is gone. The hospitals sometimes have an entire facility that they've built and dedicated to that equipment. So now that the equipment becomes useless, that's just a lot of money for the facility also becoming useless, and that serves no one. As to whether I believe low field MRI offers a very good solution to this, yes, I do. For one, MRI comes with a lot of safety issues. Part of it being SAR, and part of it also being that the magnetic field is so strong that people can't get near it. Therefore, there has to be dedicated facilities for those specific scanners. With low field MRI, a lot of those is gone because we have permanent neodymium magnets that people can even walk around in several cases. That's with the ultra low field scanners. Then, of course, there are low field ones that don't require. Um, uh, there are low field ones that you can't even go near with metals, obviously, with much higher field than the 64 millitesla of the hyperfine. And from what I have seen, like during the African chapter ISMRM conference that was held in Tanzania, where we got to see one specific low field scanner, the images are not that bad. They are not 3 Tesla or 7 Tesla scanner good, but for diagnostic purposes, they are okay. And from what I have seen with regards to my research, though the images come out of the scanners not looking the best, there are a lot of pre-processing tools available, which a lot of the times we don't have access to, that do a lot of wonders when it comes to improving the quality of the images. And they work. They have been verified and tested on several fronts, and they are very mathematically robust, and they can improve the quality of the images using a lot of testing and tweaking to make those tools work specifically to the type of scanner we want to apply them to. But once we have a very good framework in place, yes, I do believe low field MRI offers a very good solution. It may not be the best because it looks like when we are talking about democratizing MR, we are looking at getting the cheapest option rather than getting the highest quality option. But I do believe we can make the images have a higher quality, and given how they are training, for example, from what I've learned, doing training to use the hyperfine isn't very difficult as compared to training to use the much larger scanners. So yes, training can be made available for all of those things. And if we are able to work on ones that we build ourselves, a lot of training on processing the images and improving their quality can also be done. One of the problems I've noticed is sometimes the manufacturers may not provide access to information that allows you to apply certain methods onto the images. But if we have ones that are designed from scratch, we already have access to information. So we can improve on reconstruction and processing in ways that are specifically tailored to the scanners that we are working with. Yeah, thank you.
Great. Thank you. Great that cheaper options does not mean poor quality. And it's important that we drive that notion on and on, that there is, despite us being using the cheaper alternative, we can still get good qualities. I'll stick with you for a bit because I'll talk about the economic barriers and sustainable funding models, because of your background in working with a company that used to sell machines. So in Africa, the GDP in healthcare is about 5.4 compared to 12% in high income countries. So this means out of pocket and healthcare for MRI is a bit expensive. In your practice, are there alternative funding ways or that you've maybe come across as in the line of practice that can be used or that have been put in up in place that have maybe helped a few companies get a MRI at a cheaper costs?
Right. Okay. Um, I know of this in Ghana. I don't know how common this is in other countries. But when hospitals are attempting to buy very, very expensive equipment, the part of the part of it is that a bid is normally released in the newspapers, where different companies offer the exact equipment to solve the problem at different prices to the companies, which the procurement people within the hospitals go through to try and find which ones are within the budget. Some companies, in an attempt to bridge the financial gap, offer the hospitals payment plans, which, yeah, they may be generous, but in several cases the equipment is still very expensive. So what I noticed some hospitals did is that they anticipate that they are going to make a certain amount of money from patients who will be using the equipment. So they use a portion of the profits that they are going to get each month as part of the payment plan that they are as part of their payment plans when it comes to the purchasing of the equipment. So when it comes to signing the payment plans, they calculate how much profits they are going to be earning. Those profits to the company that sold them able to, the hospital doesn't get the projected inflow of patients that they expect, of course. And sometimes, from what I've seen, companies do want to come in and just dismantle or take back their equipment because they are not getting back the money. In several cases, which is normally the case when it comes to very expensive, really expensive equipment, it's either a politician with a lot of money who wants to get a lot of votes, donates a huge amount of money to the hospital to purchase something. In some instances, not really understanding the technicalities of what the hospital needs. But yes, either that or funding bodies that are trying to engage in research put together some amount of money to provide equipment to the hospitals, which has been the case with several places where hyperfine scanners have been made available because of the things like the Unity project, like the Kolebu Teaching Hospital in Ghana, and I think there's a hospital in the northern part of Ghana, have had access to low field scanners specifically because of the Unity project. I don't believe any of these are wholly sustainable because they rely a lot on factors that cannot be controlled. And I do wish there is a much better alternative. But in my opinion, one of the major problems is just a lack of priority when it comes to quality healthcare, particularly when it comes to budgeting within countries and a lot. I feel like sometimes there's just very little priority. If they have a model that seems to work okay, there doesn't seem to be the urge to um, put in a lot of funding towards making it push, which then puts the responsibility on other external uh, sources or bodies or even the hospitals themselves to try and find ways of raising their own funding to get it. So yeah, a lot of the MRI scanners, a huge chunk of the MRI scanners in Ghana, for example, are owned by private facilities as compared to government facilities, which should, I think it should show the gap when it comes to priorities. Yeah, that private individuals have to be the source of a lot of the major MRI scanners in the country.
Yeah, yeah, then great. Uh, Tom, as you also talk about the economic barriers, because you mentioned about not having an MRI in your current facility, and you also mentioned that you've used a low field scanner before. So I'm trying to look at the technological innovations and adaptations that can be integrated even in a low field machine, so as to get, because you said it's despite being cheap does not mean poor quality. Is there provision for that in your line of field, and how did you mitigate that?
Yes, there is. There's this recently, I think a project was funded recently for democratizing MR, which is being led by lots of researchers from all across the world. And the people involved are really, really knowledgeable. I think Professor Andrew Webb is part, and I noticed my supervisor is part of it as well, Professor Derek Jones. And there's a lot of very knowledgeable people working on this. And the goal is to just take the low field scanner, try to improve upon several things, make the images as robust as possible, improving upon hardware design as well as processing design with methods looking at reconstruction and improving upon the image quality as well. From what I have seen, if we have access to the images and then people have the technical know-how on what mathematical methods and what statistical methods to actually apply to the images, the qualities can be relatively improved. Obviously, with a lot of research to tune it to the specific kinds of images we are using, and or the specific scanners, obviously, and try to reduce hallucination as much as possible. I have gone to read about some reconstruction techniques that attempt to reconstruct the images while taking into account statistical properties of the image compared to noise. When those are taken into account, the reconstruction process is tailored to maintain the statistical properties of the image while reducing the noise as possible. There are several iterative reconstruction techniques like this, like compress sensing, and some joint reconstruction methods that I have had the privilege of learning of, where if you take multiple images, just using the fact that the images contain the same structures and noise is obviously what is independent, you can apply that information into the reconstruction to try and then separate the images from noise. Those are obviously techniques that have been applied, and they just require an access to the images in their raw form. And if you're able to apply it, you get it. I wouldn't try and say that you will get the exact thing that you will see on a 7 Tesla scanner or a 3 Tesla scanner, because inherently you are fighting a hardware limitation and you are fighting a physics problem, uh, obviously. However, from what I have seen, when a lot of very good methods are applied, yeah, the image qualities are improved to a very significant degree.
Okay, Tom, is because you're concerned with the noise and how you can separate it, is AI something you've managed to integrate in a low field scanner?
Thank you so much, Cliff. Once again, I want to stress some points here. Joshua has spoken much, and I appreciate him for all that information, especially looking at his background in biomedical physics. So, but as a technologist, as an imaging technologist, what we look at is producing a high quality image, which is idealistic enough for reporting. So where are some of the barriers? One of them, like I told you, knowledge gap, which we thank God that so many partners are coming up to address that. Then we have the economic gap. Okay. I am an imaging technologist, and this is an MRI low field, whatever, owned by a private partner, owned by a private company and or private hospital. And if, public hospitals are not in the picture. For example, in South Sudan, for example, in Uganda, public hospitals, I think we have only one public hospital, and which is also struggling with maintenance. You may find an MRI breaks down and there is no funding to replace or maintain. So, and like I told you, knowledge gap. I know before I actually learned or got confidence to learn MRI, we only used to have one individual who used to run it in the unit. When he's going away, the machine stops to work. So we also closed down business. You understand? And not until I got in touch with the ISMRT and somehow got interest in this and got some knowledge and confidence. That's how I got empowered. And in turn, I became the mentor in the unit. You understand? So there is knowledge gap. Then now, what we're talking about is image equality. Now, for a patient to benefit from a radiological service, an image must be produced and reported. Now, how do we get these images? For example, we have scarce labor. We also have scarce, highly trained doctors who can report these images on site. They are not there. So how do we mitigate such problems? Normally, we do what we call remote reporting, and that comes with costs. You have to put in internet to report images. You have to have internet running 24/7. It's even worse with mobile companies which provide data for a short time. Maybe Elon Musk is going to save the country by bringing satellite internet, which is quite cheaper and faster. So there are so many challenges. Like you've said, okay, there are so many limitations in producing these images. Chilongulo has said he has been doing only brain MRIs for a very long time. I think he's a brain MRI specialist now. That means that's a limitation. With a low field, you are limiting the number of investigations that you do. For example, when we are using low fields, we are able to do neuro imaging. We are able to do basic musculoskeletal imaging, okay, with good precision, by the way. You are able to do infections like TB. Yeah, you can map out TB on a bone. You can map it out in a tissue structure. You understand, with the low field. Now, when it comes to functional imaging, we are completely cut off. You can't do it. You basically cannot do it. Now, how do we solve such problems? Actually, we just refer patients, and you're referring a patient who needs now, let me give you an example of a patient with a stroke. We say that a stroke patient, when a patient gets a stroke attack, within 6 hours, you should have run a brain MRI. Now, these patients come after 6 hours, and we find that some parts of the brain have already started becoming hypoxic, and they have died. That means an MRI cannot save beyond 6 hours. We now just do brain CT. So when you look at that, we do not just need low field. We need a high field imaging. But of course, like we've said here, what we are going to mitigate the scarcity problem, the accessibility problem, is we will need low field, which is of course true. We need it. But like, as I have highlighted the gaps in affordability, these are patients, some of these patients do not have food to eat, and it's a private company giving them what? Giving them a service, and I cannot give you a brain MRI for free, even though you have not eaten for 10 weeks. So you understand. So this comes at a cost and at a population which is disadvantaged. They don't have the money to do. First of all, they are crying of hunger. They cannot afford hybrid imaging. And we know the safety of MRI. We know. So there's just a lot that needs to be done to really revolutionize the MRI best practices in Africa at large. Ghana may be blessed, but I think for Uganda, South Sudan, we are still, but we hope that things are changing. We are praying that AI, like you've asked, how do we improve AI? We said AI can be applied in reconstruction to improve on image quality. You can use it I do not know how that is possible, but in one of the conferences, they say you can integrate AI in improving image quality, and also in reporting. So I hope those solutions come into play. Then maybe how do we solve the issues of prices, expenses? If it is a private company, I do not think we're getting out of that problem very soon. Maybe we pray that the public, the federal governments in these states partner with the private companies to provide subsidized costs to the patients. Thank you so much.
Great. So you mentioned about the knowledge gap, and you highlighted what you are going to briefly talk about workforce development and the social factors. So Jackie, I'll throw this to you because you've been a beneficiary of the international partnerships for building training capacity. So is the international partnership the future and the way to bridge these gaps in MRI?
Thank you very much, Cliff. Again, thank you everyone for this amazing session. It's been such a success, and I have learned so much from everyone. And my answer is yes, Cliff. I mean, as I always say, learning never stops. And the thing with learning is that you can learn from anyone. We can learn from each other, but it's even better if we learn from people who have already done what we are seeking to do, because we don't really need to reinvent the wheel. So yeah, I mean, the trainings and everything, especially now, like Tom mentioned, and in calls whom I have been part of the ISMRT Future Leaders with, we've seen like the impact this has created, just like having people from different walks of life and have them being able to access these things, even if just remotely. I mean, I do acknowledge that it takes a lot of money to cross someone overseas and bring them like abroad to study. Like me being here at Cardiff has probably costed a lot, and not everyone will have the opportunity like I've had. But these are the things, like having these things remotely, like attending sessions like this, or attending trainings by camera or by ISMRT Future Leaders. I mean, we have seen in the recent 2 years a rising number of more training programs. And I think if we embrace these, if we are in a position that where you want to learn, then you'll definitely find a platform where you can learn from. So yeah, partnerships, definitely a great way to learn. But if you don't get the opportunity to travel or have that one-in-one from another country, then definitely interact with these people even online. You still get to learn so much. Yeah, so thank you, Cliff. And I think it's also more accessible to a much larger population.
Thank you, Zaki. So as we wind up, Cowles, as you give your final remarks, you can also talk about the same international partnership, because you're in the ITMRM African chapter. Also, can briefly tell us about what the future is about in bridging the gap with international partnerships.
Right. So one of the biggest advantages that we have had here is that the first MRI that was donated to the Belanta Malaria Project was a donation from Michigan State University. And so there has been a lot of collaborative efforts with the university in terms of training. They used to send us their radiographers to give us periodic training, which really helped us to grow in terms of knowledge. But in terms of other than that, we also had other universities who came to collaborate with us in terms of doing the MRI research activities. So, for example, we had collaborators from Liverpool, University of Liverpool, the Wellcome Trust, which brought another study which we did. It was a study which was done here and in Cape Town. And so we learned a lot from their collaborative mechanism, which added on top of the already the one which we had from Michigan State University. We also had another collaboration with the University of Washington. And so all these efforts really brought a lot of information that reduced the knowledge gap in terms of our MRI services. For the ISMRM, what the aim of that program was to give us, especially those in the low-income countries like Malawi and Uganda, Kenya. So we developed a program in which we were doing training programs, and also we formed divisions within our own countries. And within these countries, what we were doing was to enroll members of the division who were either doing MRIs in their stations, or they were expecting that in the near future they are going to do MRIs. And so we formed divisions in which we were also teaching ourselves on how to do the MRI scans. And this helped quite a lot because they were supervised by a professional who was someone with a lot of experience in MRI. And so by their supervision, it brought a lot of enthusiasm and brought the knowledge gap to a minimum. So for example, I was the only MRI radiographer in Malawi in the past up to 2022 or so. But after that, the coming in of the ISMRT, we are now more than 20. Those who have been trained locally. Although the challenge in terms of training is that we don't have a formal training in any of our universities. And therefore, if one wants to train, they have to go outside the country. But learning from these short courses and collaborative efforts, it has really made something out of nothing. And then when the Bill and Melinda Gates Foundation introduced the scholarships for people to join the divisions, we were able to attend the conferences. As Joshua said, we went to Singapore, we went to Toronto, even up to Hawaii for the conferences, which also helped us to learn quite a lot. So a lot of efforts are being done, they're being achieved, and we are very, very happy that in the absence of formal training, we are still able to do MRI with high quality, just like any other person. There was also one of the things that we benefited out was the use of simulator training, which came from the ISMRT, but also we had an advantage. We had a chance to interact with RAD-AID. I don't know whether you have heard about RAD-AID. It's an American organization which tries to bridge the knowledge gap in terms of radiography. So RAD-AID came in with their own
We've lost you, Calls, and you're on mute. Okay, sorry for that. So as we wind up, Joshua, could you give some remarks? Oh,
Yeah, okay. I hope I'm not muted, right? I don't really have a lot to say, just at least very grateful that this whole thing is even organized, and I'm very privileged that I could even be considered part of it in any way. Yeah, I do feel like obviously the journey ahead, if it comes to making the technology and the research readily accessible to everyone, is very difficult, as you know, there's a lot of problems from knowledge, infrastructure, training. Uh, yeah, it's complicated. However, I believe very strongly that if we keep pushing, keep working together, keep seeking to find solutions to the problems, with time, we would eventually get there. It's a long journey, but we don't get there if you don't move. So, yeah, thanks.
thank you so much. Calls, you're back.
yes.
Yeah, yes, you can
Can you,
finish
can
your
you hear me?
work. Yes, we can.
Right. The last thing that I wanted to say was that um,
We
the
lost your track.
problem of hello.
Yes.
Yes, I was saying the problem of shortage of personnel in terms of medical physicists or radiologists is also affecting us, because we haven't had training for radiologists in the country. Most of our radiologists, they come to Kenya or South Africa, but when they finish, they end up staying there. And so it has been a very big challenge. And as you mentioned earlier, the issue of AI and teleradiology has been one of the substitutes in the absence of those trained professionals. We have a new university which has just opened, and they have introduced a biomedical engineering course, and we hope that eventually we will have medical physicists trained from there. Probably, I think that's where we are heading. Thank you.
Thank you so much. The access to the available learning platforms is the way to go indeed.
Yeah.
Tom, thank you. Tom, any closing remarks?
Yeah, I hope I'm audible enough.
Yes.
Thank you so much for bringing this conference all together. I think it's the right time we talk about Africa and how to improve. Like we've discussed earlier, the best solution, I think, is still the low field MRI, which is more than just a machine. It's a tool for equity, access, and innovation.
Sorry, Tom, we lost you. Uh, okay.
Can you hear me now?
Yes, yes, we can.
Yes.
Can you hear me now? Am I
Yes.
audible enough? Am I audible enough? So I was saying one of the biggest solutions we have now is low field MRIs, which is just more than a machine, but it's a tool for equity, access, and innovation. A reminder that technology, when applied thoughtfully, can solve real world problems rather than create barriers. Like we have said, for poor image quality, we can mitigate by improving on the software, and we can also improve on integrate AI to mitigate poor image quality in these low field MRIs. It is now a moment for us to seize these advancements in technology and use it for the benefit of our patients. When we embrace these low field MRIs, I think we'll have saved a lot of lives and will have shaped the future of our healthcare in our continent in general. So I want to say thank you for inviting me to this conference. Thank you so much.
Thank you. Thank you so much, our panelists. There are many challenges in MRI, but where there's a challenge, there is a solution out there. So as we collaborate, so do we achieve more. I want to take the opportunity to pass my gratitude to every one of you for your time and your insights for this session.